In this video, we demonstrate a humanoid-assisted, minimally invasive gallbladder removal performed in a pig model. Gallbladder removal, also known as cholecystectomy, is one of the most commonly performed surgical procedures worldwide. In the United States alone, approximately 650 to 750,000 of these operations are performed each year. The procedure is typically used to treat conditions such as gallstones, inflammation, or infection of the gallbladder, and less commonly, gallbladder growths or cancers. In a minimally invasive cholecystectomy, the surgeon removes the gallbladder, a small organ beneath the liver that stores bile. This is performed using several small incisions rather than a single large one. A camera provides a magnified view inside the abdomen, while long, slender instruments are used to carefully separate the gallbladder from nearby blood vessels and bile ducts. Cholecystectomy is often used as a benchmark procedure in general surgery because it requires a combination of core technical skills. These include careful tissue separation, accurate identification of anatomical structures, secure closure of small blood vessels and ducts, and controlled use of heat-based instruments to cut and seal tissue. Porcine or pig models are widely used for surgical training and research because they reproduce the main steps of human gallbladder surgery and require similar tissue handling skills. Here we show the port placement we used for these porcine procedures. For these procedures, the humanoid robotic system was positioned at the patient's bedside. Visual markers were used to track the locations of the surgical ports, allowing the robot's movements to remain aligned with the surgeon's commands at the control console. Using standard access ports, the robot was connected to a laparoscopic camera and specialized surgical instruments with wrist-like joints that can enhance tissue handling and separation. We begin the operation by identifying key anatomical structures, which include the gallbladder, the liver, and the cystic artery and duct, which carry blood and bile to the gallbladder. After identifying key anatomy, the surgeon begins clearing tissue near the junction between the gallbladder, liver, and bile ducts. This step gradually exposes the structures that must be clearly seen before the gallbladder can be safely removed. During this phase of the operation, the surgeon worked from a control console. The surgeon's hand movements were translated in real time to the humanoid robot's arms at the bedside, enabling smooth and precise instrument control. This console-based approach also improves surgeon ergonomics. Gallbladder surgery often requires sustained gripping and fine wrist movements, which can be physically demanding. Operating from a seated console reduces physical strain and resembles the workflow of established surgical robotic systems. A second humanoid robot was used as a bedside assistant to help with holding tissue and adjusting the camera. Under the surgeon's direction, the robot maintained a clear view of the surgical field. This approach reduces the need for a trainee to serve as a dedicated bedside assistant, allowing that trainee to focus on learning key steps of the operation instead. Before clipping or cutting any structures, the surgeon confirms what is known as the critical view of safety. This involves fully clearing the lower portion of the gallbladder and confirming that only two structures, a bile duct and a blood vessel, enter the gallbladder. This step is essential because it significantly reduces the risk of injury to major bile ducts, which can result in serious complications requiring extensive surgery. In these cases, the critical view of safety was achieved without difficulty, and the two structures were identified, secured with clips, and divided. The humanoid system is also compatible with human bedside assistants. We transitioned to a human assistant before separating the gallbladder from the liver. The compact size of the humanoid robot allowed the assistant to work comfortably at the bedside, with more available space than is typical for conventional surgical robotic systems. To complete the procedure, the gallbladder was separated from its attachment to the liver. This step requires steady, fine motor control and careful use of energy to minimize bleeding. Across both procedures, all key steps of gallbladder removal surgery were completed successfully. These included clearing tissue off structures, manipulating structures, using energy to divide and seal tissue, and obtaining the critical view of safety. The humanoid robotic system integrated smoothly with conventional operating room workflows and standardized insufflation systems, ports, and cameras. Limitations of the system included a restricted range of motion, longer setup times, the need for grip adjustments, and occasional interruptions for troubleshooting, instrument recalibration, and overheating. In these controlled in vivo procedures, the humanoid robotic system supported complex, multi-step general surgery while maintaining established principles of anatomical identification and surgical safety. This work represents an early step towards the future integration of humanoid robotics into real-world surgical practice.